So welcome back, everyone. I'm your new chairman for this track. And my name is Mark. We are going to have Professor Peter Cameron to give us a talk. Professor Cameron is one of the past directors of our academic unit. He is also the past president of the Australasian president of the IFEM. He is currently the academic director of the Alfred Emergency and Trauma Center. His extensive history of practical involvement in healthcare. Please start, Professor Cameron.
Hi, great to see not to see everyone, great to be online and to talk with everyone in Hong Kong. I would have much prefer to be there and enjoying your great company, but unfortunately I can't be there. So this is second best. What I'll do is share the screen. And we are talking about the future of trauma centres. Now, unfortunately, that's gone to the wrong thing again. Hang on. There we go. Okay, so I'm talking about the future of trauma centres, which has caused a lot of controversy. I know it's been a big controversy in Hong Kong over the years. So it's good to be able to reconnect and talk about this topic. In the past, trauma has been very much a hospital specialist model. So based in highly specialised facilities, staff are highly skilled, patients are served up to the specialist. There's diagnostic certainty and clear goals of care. The WHO more recently has sort of started to talk about emergency and trauma systems. And certainly we have been banging on, as in the emergency community, have been banging on about this for some decades. The good thing is it is gaining traction, and it means that we need to think not just about the little bit at the end, the hospital or the specialist operating theatre, but all the bits that go together to make a trauma system. So the way we are alerted to a trauma, the access, the transport, the scene management, integration with the emergency system as a whole, the different teams of skilled people, and obviously, where appropriate, use specialised services and triage people to the right places and treat at a community level when safe, and obviously integrate back into the community. In this domain, emergency physicians are king. We know about resuscitation, we know about assessment of the whole patient, we know about risk assessment, we know about coordination of multiple specialties, we know about imaging protocols and safe discharge. The military model of trauma care that really the whole traumatology science has been based on is really not relevant to advanced economies in the 21st century. So in the 21st century, major trauma is old people with falls, multiple comorbidities, multiple medications, head injuries that are not comatose, skeletal thoracic injuries, questions about goals of care for older people, and obviously evidence base for geriatric trauma in terms of how we manage spines, TBI, etc., for this particular group. The operative part of it is actually a very small part, and when we've looked at it in Australia, it's been sort of less than 5% of cases, other than orthopedic nuts and bolts stuff. And just to add to that, more than a third are over the major traumas that come to the major trauma centres are over 65, and much more than half are over 45. But when you get to the deaths, 3/4 are in the 75 to 85. So the people that are at risk of dying, which is the whole purpose of trauma centres in the first place, are basically old people. And just to make the point that only about 5% of severe heads are comatose when they come in. So the basics of resuscitation. So ATLS has been the standard. I know it's been a big thing in Hong Kong. Is it still relevant? I'm not sure, but it's certainly a useful communication tool. If you go to the ABCs, we'll talk a little bit about airway and cervical collar because that's changing and we are driving that. The first thing is the C collar is basically on the way out. So most major jurisdictions now, apart from the US, are reconsidering the use of collars because there is no evidence base for their use. Airway control, obviously, we want to avoid hypoxia. That's been shown, and hypoxia and hypertension are bad for head injuries. This is one of our key emergency medicine skills. We're good when, with checklists. Obviously, in the airway area, it's a high risk area, but we've got to be careful about not using checklists for everything, but certainly in the airway, it has been shown to make a difference. The drugs we're standardising, again, we've driven this, certainly in Australia, the emergency physicians have driven standardisation of protocols for head injuries. We've got rid of Sux and Thio. We're now mostly using ketamine and rock at a pretty standardised dose, and specialised equipment. The video laryngoscopy is now pretty much standard, and again has made it a lot easier, I think, for emergency physicians to be king of this domain. Breathing wise, we've changed the way we do the needle thoracostomy. Really has been shown to be not very effective when we've done CTs afterwards. Obviously in a dire situation, you might do it as a temporising measure, but really we should be moving to a finger thoracostomy where there is a concern about tension. And obviously we've learnt not to put a chest tube in everyone. The ventilation side has really changed a lot, and depends on whether they've got a head injury or not, but we're looking at lung protective ventilation versus brain specific ventilation. And depending on what the sort of major problem is as to how we balance, sort of like hypoventilating versus maintaining optimal oxygen delivery. So this is something, again, that we're quite good at. The circulation side, again, has changed a lot. Intraosseous has come back in, rapid infusion lines, ultrasound. These are our core skills. Fluids have become more restrictive, less salt, more blood. And of course, with massive transfusion protocols, we're looking at it, whether it's 1:1 to 1 or 1:1 to 2, probably doesn't matter too much. TXA, there's still a little bit of controversy about in advanced trauma systems. Ian Roberts thinks that solves everything. I think there is a different view in Australia and some other jurisdictions. But it's probably not going to make a lot of benefit when you have access to good massive transfusion protocols in theatre. The return of the tourniquet. When I was a youngster, we used to use tourniquets. They got rid of them because they had complications. But again, there's a place, especially for amputations and stuff, to use tourniquets in the initial phase. I'm not too sure about topical procoagulants. Certainly Reboa hasn't really been shown to make a lot of difference. But what has made a lot of difference is interventional radiology. We rarely take out spleens or livers, and intervention, and certainly with pelvic bleeds, interventional radiology works, and we rarely have hemorrhagic deaths. On the D for disability, in the minor injury side, I think we've made some major leaps forward with concussion. I think it's probably been overdone, but certainly at a minimum in the ED, we should be using memory tests such as Westmead's beyond the GCS. But more importantly, we've shown hypothermia is not particularly good for heads. Intracranial pressure monitoring, again, not a lot of evidence for that. Decompressive craniectomy is okay if you want to have a slight increase in people who are disabled. In terms of good outcomes, it makes no difference. And there's a little bit of work in the seizure area, and we're now looking at continuous EEG monitoring for some of the more severe head injuries. Basically, most intensive care units in Australia and New Zealand would use intracranial pressure monitoring, but in the US, the studies that have been done haven't really shown any improvement in outcomes. And the use of anti-epileptics for patients with post-traumatic seizures, it's certainly been shown to reduce early seizures. There's not a lot of evidence for long-term outcomes, so mostly people are only using it in the first couple of weeks. And generally avoid hypothermia. Even in head injuries, the Eurotherm and Polar studies are convincing that we shouldn't really be using hypothermia as a therapeutic tool, although we want to avoid hyperthermia. Now, imaging is something we're pretty good at. We certainly have the most systematic approach to imaging. We know the CT head rules. The role of pan scan, I think, is something that has been debated, but on the whole, pan scans, in patients that are at high risk, are probably worthwhile rather than going back and looking at doing multiple segmental scans. And as we've said, interventional radiology has basically turned trauma into a non-surgical disease. So I think the CT head rules and the similar ones for children have made a huge difference. So I think there's a lot less unnecessary imaging for these cases. And this is just about the pan scans. The evidence is sort of contradictory, and as you'd expect, but I think the main point here is that if the patient's had a decent injury, then rather than just CTing one part of the body, you're probably better off to do a pan scan, because you'll end up overlapping scans and actually causing more radiation. Thromboembolism in trauma is pretty controversial. There was a study from Perth that was too small to be powered to make any difference. But in terms of IVC filters, but there's certainly we should, if there isn't imminent risk of bleeding, then they should get early low molecular weight heparin. Where that's not feasible, certainly at the Alfred, we're using intravenous vena cable filters. But the evidence is problematic because it depends on your complication rate, how long you leave them in for, and so forth. But we've had very few deaths from pulmonary embolus over the last few years by using filters. So getting back to the point, we are the systems people. Trauma systems rather than trauma centres has been our mantra for the last 20 years. How we talk about trauma systems, I think, has varied between US, UK, Australia, Hong Kong. What we mean is slightly different, but it should include everything from the access point to when they leave rehab, and even the follow-up over the next year or two. So we need to measure that, and we need to benchmark against each other. And I think in terms of the way we look at trauma patients that come into the ED, I think there's a good place for trauma care checklists. We certainly have a tertiary survey here, and I think when I left Hong Kong, we were doing a tertiary survey, so hopefully that's still happening. But I think, re-looking at the patient after that initial phase is quite important. So really, emergency physicians are used to being a team leader. We should be taking on the system leadership. And that certainly in Australia includes taking on the telehealth support for regional hospitals, developing care coordination packages for specific injuries such as chest and head injuries in the elderly where they don't need surgery, and also retrieval coordination. So the ED physician has the training and the mindset to lead trauma reception resuscitation room. No other clinician has the appropriate training. The emergency specialist must drive the system coordination. And really, I guess the old concept of the North American Trauma Centre run by surgeons isn't really relevant to the trauma that we see in the 21st century. Thank you for giving me the opportunity to talk, and happy to take questions.
Thank you very much, Professor Cameron. That's a very interesting talk. I would like to ask a few questions. In your talk, you mentioned ATLS may not be relevant at this moment, but it may be still very good use as a basis for communication. What would your recommendation on the standardized training if we are trying to get rid of ATLS?
Yeah, so I think, for surgeons and people, the occasional players in trauma, then I think something like ATLS is a good language for them to learn. I still teach on ATLS courses once a year, and just for the fun of it. But I think for emergency trainees, I think it's important that they do. Obviously we already know the ABCs. It's not something new to us, so it's pretty basic stuff. But what we need to be able to do are things like trauma procedures. And so, for example, in Australia, we run a trauma procedures course. We run a airways course. These sorts of things, which are core skill, and ultrasound courses are core skills for people managing trauma. And we should obviously be expert at those skills, which go way beyond ATLS.
See. Next question. I saw on your slide you mentioned Reboa. And actually in Hong Kong, a few trauma center is trying to start a Reboa system. So what do you think about Reboa? Where should we go? I mean, what do you think about the future of it? Or is like some sort of fool's errand, not worth investing in it?
Yeah, personally, I think in a place like Hong Kong, which is urban trauma, advanced economy, I think it's probably a waste of time. The transport times are short. The only reason really, I think, for something like Reboa is where you might want to temporize whilst getting to theatre. I think if you can get them to theatre, then that's, or to interventional radiology, then that's what should happen. We've had a limited experience here. We did try to start a Reboa program, but we had one case in a year where it could have been useful. That's at the Alfred, which is, sees quite more major trauma than any of the Hong Kong places. My feeling is that the concern I have with it, I guess, is that it might delay appropriate definitive treatment because people are messing around trying to, place the catheter, and that would be a bad thing when they should have just raced them to theatre or raced them to interventional radiology, which would have sorted the problem out. So that's the danger. And the other problem is if you're only doing it once or twice a year, your skill level is not that good. I mean, obviously you can practice on cadavers and things, but it's still, I think it's like all these things like, ECMO and resuscitation, all these things, you've got to have enough cases to maintain the skill and maintain the process. You know, even having the nurse that helps you and the radiology and all that sort of gear. If they've not done it for 12 months, it'll be very rusty. But I'll be interested to see how you get on.
Right. So, you also mentioned about the neck collars. So, in the outfit, do you get rid of all neck collars?
Well, it's an interesting question. So, in Australia, Queensland has got rid of collars, and New Zealand has got rid of them. In Victoria, we've been quite slow, which is where the Alfred is. We have started to take a more liberal approach to using collars, or not using them. Over the next, say, 12 months, we're going to gradually step back from using collars. Mainly because our Director of Trauma, Mark Fitzgerald, who many of you will know, is very conservative on this, but the ambulance and the ED people are keen to just get rid of them. But we're sort of, you know, balancing, I guess, everyone's opinion. But the experience in Queensland, where they've been doing it for about 3 years, has been there have been no adverse events, and obviously much quicker mobilisation, especially the elderly who are most at risk from immobilisation. So short answer is we're still using collars at the Alfred for most cases, but we hope to change that over the next 12 months.
I see. So when you say they get rid of the collars, that are you saying they don't use it even in the pre-hospital setting?
Yes.
Okay.
You've got to understand the evidence base for their introduction was basically zip.
All right. Thank you very much, Professor Cameron.